and good evening, depending on where you're joining from. And on behalf of the APPNA MERIT Medical Education Research International Training and Transfer of Technology Subcommittee, I would like to welcome all of you for yet another of our research and innovation landscape in Pakistan webinar series. This is a series that we have been doing for over 2 years almost now, and we do it every 2 weeks. And this time we are talking about the role and contribution of industry, specifically with Getz Pharma for partnership in clinical research. My name is Sarfraz Hasni. I'm a clinical researcher and a rheumatologist, and I'm director of the clinical research at the National Institutes of Health here in Bethesda, Maryland, in USA. And we have panelist Dr. Syed Uzair, who's always here, and our technical support is through Waleed and his team, which we are very thankful. He's very professionally conducting all these, helping us. In terms of housekeepings, if you have any questions, please put them in the Q&A that you see on your right side when you log in. Please introduce yourself in the chat box, and Dr. Uzair is going to be manning the chat box in Q&A. With that, I would like to introduce our speakers for today. So first is Dr. WAJIHA JAVED, who is the head of public health at Getz Pharma. She's a medical doctor with a public health degree, and she's been working in the developmental sector for 15 years. Her experience includes strategy, advocacy, capacity building, and rolling out of natural level implementation projects with various donors, including DFID, USAID, Bill and Melinda Gates Foundation. She has a special interest in scaling up family planning and non-communicable diseases. And currently she serves as, I mentioned, as the head of the public health at Getz Pharma. Our next speaker is also a senior medical director at Getz Pharma, as Dr. JAHANZEB KAMAL. Dr. Kamal heads the medical affairs, and he has 20 years experience in healthcare and pharma industry. He has an MBBS degree from Dow Medical College and also an MBA in marketing from Institute of Business Management. And he's certified in medical affairs and medicine development from King's College London and Tufts University. And he recently completed MCPS in healthcare systems management from the College of Physicians and Surgeons in Pakistan. And he's the author and co-author of more than 15 publications. So we would like, on behalf of the APPNA MERIT, to welcome both of you, and I will hand it over to Dr. WAJIHA JAVED to please take it over. Thank you.
Thank you so much, Dr. Sarfaraz, for the introduction. So I would like to thank APPNA MERIT for inviting industry partners like Getz Pharma on this platform. We felt that industry has always been viewed as a lens that they're not there in implementation, or they're only sponsors. So we wanted to point out and bring out certain projects of ours at how we are linking up with research in Pakistan through a different lens. So the session today will partly be presented by me and then partly by Dr. JAHANZEB, who's our Senior Director of Medical Affairs. I'll be focusing on the non-clinical community side of research, and he'll be looking into the clinical trials that Getz Pharma is looking into. So I've taken the opportunity today to highlight 2 of my projects within the public health department. One is by the name of PAK-SEHAT, which is a longitudinal cohort study, which we're doing with partnership with WAJIHA, and the principal investigator is Dr. Bashir Hanif. And the other one is called PREACH, which is an implementation project which spans nationally, and I'll be talking about it. So I'll be splitting my time highlighting both of these projects only as an example. If anybody by the end of this is more interested in anything, we can point out other projects of ours also that we have been working on. Would you please start? Okay. So PAK-SEHAT, from concept to implementation, this was a project which was actually the brainchild of the ED of the WAJIHA Institute, Dr. Bashir Hanif. I'll be going over the idea and concept behind PAK-SEHAT, a brief overview of what the protocol and processes are, and where we are in terms of the project, recruitment screenings, and the timelines, etc. Since all of us here are medical professionals, I'll very quickly go over the first 7-8 slides, which highlight the background rationale behind PAK-SEHAT. The age-adjusted CVD prevalence globally at the moment is 6.1%. Southeast Asians are especially highlighted because of our comorbids and our genetic makeup. The World Heart Federation ranks CVD as the first killer of diseases, and we have 18.6 deaths happening, 18.16 million deaths happening globally from CVD. And 75% of these deaths are happening in LMICs and MICs. So you can imagine the burden of disease on an already staggering economy. So the protocol behind PACSET was that ASCVD is the prime root cause of cardiovascular disease, which is contributing to major morbidity and mortality worldwide. Remains the major cause of death by 2030 as per estimates. ASCVD accounts for 31% of annual mortality worldwide, 85% of cardiovascular mortality, and risk of ASCVD varies among different ethnicities. However, the risk is around 4 times more in the Southeast Asian population as compared to other races. Pakistan, could you remove this thing? So in Pakistan, the number of deaths that are happening per 100,000 population because of CVD is almost 423, which is huge. In 2019, CVD was the second largest cause of death in annual morbidity and mortality, whereas stroke and diabetes in Pakistan were the 6th and 8th leading causes of mortality in Pakistan. So as you can see, ischemic heart diseases come on number 2, and stroke and diabetes are 6 and 7, which are comorbids. And this is among all the diseases across the lifespan, because neonatal cause of death are the first, and then we have diarrheal and tuberculous and infectious diseases. So NCDs are on a rising trend in Pakistan. So at the moment, we're facing a triple burden of disease. Similarly, Pakistan in 2021 was the 3rd largest country within the world having the maximum number of people living with diabetes. And we're supposed to double up if we do not stop the current trajectory, and we will double up to 62.2 million in 2045 if we don't do something about it. Similarly, we're in the prevalence of hypertension in the adult population. Almost every 1 in 2 person in Pakistan is a diabetic, and these are community figures that have been taken out from community studies. According to estimates, it'll go up to 60% in the coming decades if we do not act now. So PACSET basically is a study, it's a joint venture between Tabba Heart Institute and Getz Pharma. Getz Pharma is a seed donor to this as well as partner to this. Between Tabba and Getz, we have split our responsibilities in terms of research, operation, logistics, and I'll talk about it in a minute in the upcoming slides. So as stated in my previous slides, the burden is very high, despite the very high prevalence of diabetes, hypertension, central obesity, metabolic syndrome. We still have higher prevalences and mortality and morbidity than we would think otherwise. And there's something more that is contributing to Southeast Asians than the other population. The major objective of PACSET study is to characterize the prevalence and severity of subclinical coronary atherosclerosis among young Pakistani men and women who are at the moment disease naive when it comes to ASCVD. And then we're looking into their 5-year rates of ASCVD events. Our secondary objectives include the prevalence of diabetes, hypertension, dyslipidemia, and any other CVD risk factors, which includes obesity and exercise and food and genetics. We're also determining the risk factors for subclinical ASCVD within this population, the incidence of diabetes, hypertension, etc., and the independent risk factors that occur in the young asymptomatic Pakistani population. Our inclusion criteria is native Pakistani. For men, we're looking into ages of 35 to 60, and for women, we're looking into ages 35 to 65. We are looking into individuals who are asymptomatic at the moment with no known cardiovascular disease, have a valid CNIC, are planning to reside within Pakistan for the next 5 years because we're doing follow-up studies, and are able to comprehend and sign an informed consent. The exclusion criteria is current pregnancy, any prior history of major CVD event. In this case, we're talking about MACE events, which is angina, MI, prior revascularization, a stroke, or a transient ischemic attack, or if they've had any heart surgery in the past. Any serum creatinine of more than 1.5, weight more than 120, any contraindication to CT, and any active malignancy. Our sample size overall is 2,000, and we have done a proportionate to sample study nationwide, which is covering all the provinces, and we've taken a representation purposively of each province, and this is powered to our outcome analysis. Our conceptual framework is that we're looking into socioeconomic factors at baseline, which is ethnicity, dietary preference. We're looking into a 2-week and a 1-month food frequency questionnaire. We're looking into ethnicity, gender, age, socioeconomic status, education attainment, dietary habits. We're looking into PQL, the exercise scale, tobacco use, any past medical history. And at the same time, we're also taking markers for genetic markers for 250 CVD genes within this, and we are biobanking it. This is also the first biobanking longitudinal cohort for Pakistan. The health outcomes, like I explained before, are explained, but at the same time, we're also looking into whether mental health has an impact on CVD outcomes or not. So we're looking into a validated stress, depression, and anxiety scale. The study is longitudinal cohort. We have baseline, midline, and endline. At baseline, we're doing these screenings, which is via data, as well as doing lab tests. We're doing a CT angio, and we're doing biobanking. In 3 years' time, we'll be following up again with lab tests, but we're not doing any CIMT in 3 years. And at 5 to 6 years, we are following up again with lab tests, CT angio, and a CIMT, again, carotid intima media thickness. And biobanking is being retained for 10 years within the study. At baseline, we have screening, lifestyle, dietary questionnaires, vitals, anthropometrics are being done. We're looking into body composition, lean muscle mass, fat mass, laboratory analysis, cardiac CT, carotid ultrasound, and follow-up data. Now, at the time of recruitment, what we're doing is that we have hired a third-party research firm because we wanted to keep things standardized for this study. And we've taken a research firm which is going across nationally to recruit our participants. And they're getting the first point of contact is at a hospital. And from a hospital, we're doing attendees of people who are coming into a hospital for getting a checkup. We're also doing active recruitment via digital means and online and offline strategies, so that people can come to us. We have a hotline also that people can reach out to us with if they're interested and they want to be part of the study. So the first point of contact is at the hospital where data is getting gathered. Then for blood tests, we have hired a partner, a laboratory partner, Chuktai Lab, who is doing home sampling for all blood tests that we're getting done within the study, which includes all sorts of markers of diabetes, hypertension, and other comorbids, as well as baseline labs like NFTs, RFTs, etc. And the third point where we touch upon the patient, again, is for a CT angio, which is happening also at a hospital, a CT angio and a CIMT. Now, an MOU signing ceremony happened. I'm going to skip this. We have IRB approvals from National Bioethics Committee, from TABA, and from the other 8 centers that are part of it. This trial is registered at clinicaltrials.gov, and you can reach out to the core study team if anybody is interested. Our steering committee comprises of international people who are the leads in preventive. We have with us Dr. Faram Nasir, Dr. Salim Varani, Dr. Miguel from Spain, and Professor Samat with us. The principal investigator is Dr. Bashir Hanif. The project core team comprises of people from the Public Health Department of Getz Pharma and TABA Heart Institute. Our regional investigators and institutes are 8 centers across Pakistan who are part of the study. Blood investigation partners, Chuktai. Research organization is PHC Global. And then we disperse volunteer disbursements completely transparently through Mizan Bank in an automated format. This is our steering committee. These are our PIs and co-PIs. At the moment, the centers that we have with us are Tabba, Peshawar Institute of Cardiology, Safari Hospital, Mediki, Doctors Hospital, Beria, Faisalabad Institute of Cardiology, and Tabba Quetta. So as you can see, we're nationally covering across all provinces and regional centers. This was a research staff training that happened. This is a CT tech training that has happened, and we have a standardized CT protocol on which the CT training is done and the CT reading is done. So we have one CT reading that is done at the hospitals, and then a core team in Pakistan at Tabba and in the US for reporting it in a standardized format so that there is no discrepancy when it comes to baseline CTs. Our awareness and recruitment strategy is both active as well as passive. Actively, we're recruiting attendance of cardiac patients from the hospitals that we are at, or people who are visiting the OPD clinics, and passive is through digital and print media. And referral from outreach sites, which could be GPs, which could be via print media. They could be coming to us via TVCs and DVCs that we've floated around nationally. The process starts off, I have highlighted it before, but I'll just quickly run through this slide. We start off with a pre-screening through our GP network, through walk-ins and through shout-out influencers. Then we have a screening enrollment process. We have interviews. We have a body composition analysis that we're doing on a Tanita machine. That tells us the fat composition and the lean body mass composition. Then we move over to laboratory investigations. Anybody who's excluded, is that excluded at that point in time? Then laboratory investigations, then CCTA testing, the final testing, and then the person graduates from the study at baseline, and we follow them up at midline and endline again. These are just various agreements and partnerships that are happening. This is the map showing the sample size distribution. So far, we have recruited 40% of the people in the study. Around 26% have graduated from the CT at baseline, which is huge for Pakistan, because this is a disease-naive population we're looking into. The expected timeline for enrollment is that hopefully they'll, as of June 2023, we have almost covered 1,000+ patients, which is 50% of those that we had to get in the beginning. So I'm going to stop here. I'll take more question answers when we open up for QA at the end. And I will now jump on to my second presentation, which I will try to keep very short. That goes by the name of PREACH. And PREACH, we have actually, so it's an implementation project on hypertension, and it's based on a socio-ecological framework for hypertension and how we can kind of control the burden of hypertension at a community setting within Pakistan. Again, I'm just going to skip these majorly because it's we know all of this. Every 1 in 2 adults in Pakistan are hypertensives. They are bound to increase to 60% in the upcoming upcoming decades. And so there are 3 different points where hypertension is actually missed out or treated or misdiagnosed or not worked at. And there are 3 areas where we, at a community level, can focus on hypertensives if we want to roll out a community project. So the first one is that from the population of hypertensives that are present, those who are unaware and have never been screened, never been diagnosed, that's 1. From those who are aware and do not seek treatment, that's 2, that is the untreated hypertensives. And then the third area is that those who are treated but are not under control, that is the uncontrolled hypertensives. So whenever you work on a community-driven project in the field, these are 3 areas that you can work on. Increase awareness of those who do not have awareness of their disease, increase better treatment of those who are not getting treated but know about the disease, and the third one is seek better control from those who are under treatment but are not getting good treatment. A meta-analysis was done in the Arab countries in 32 different countries, and they showed that from awareness to control, we almost lose up to 60–70% of patients. So even if an awareness is 100% within a country, it goes to as low as control of any particular disease. In this case, hypertension goes as low as 35 to 40%. And that is attributed to a lot of attrition that I talked about in the last slide. If we are to work on hypertension, there are 3 areas where interventions globally have shown to reduce GIF reduction. If we are to make the hypertensive population in any country aware of their disease, almost 8.2% reduction would be done of hypertension if we just talk about awareness at a community level. If those who are aware, we start treating them, a reduction of 3.3% will happen at a community level in the overall burden of disease in a country. But the easiest and the one with the largest impact is that if we start working on treatment and do better control, we look into a risk reduction of 12.7% at a community level. So the highlight of this slide is that we need to work on better control and we need to work on awareness if we are to control hypertension at a community level. Now, in Pakistan, the rationale for PREACH, which is prevention, management, and control of hypertension, came out that when we saw in Pakistan, we saw that there was no standardized approach. We did not have national guidelines to treat hypertension. And GPs across the spectrum and secondary and tertiary care hospitals were all treating hypertension according to different guidelines. There was no one standardized national guideline. By the time any patient became aware that they had hypertension, which is a silent killer, they would have landed up at a tertiary care hospital with one organ damaged already. Because it's a silent killer, there are no symptoms. People usually find out about hypertension once they have one organ involved. In developing countries, we do not have the resources to manage complications of hypertension that lead to stroke, etc., because obviously it's very cost intensive. But if we look into early surveillance and community screening, that's the only means of detection of hypertension early on in the community. And per individual, it adds up to almost 10 to 15 years before an organ damage shows up. And early detection also means better polys and DALIs and more effective, more cost-effective implementation model at a national level when you talk about costs also. The overall shift should be from specialist care to GP care and from treatment onto prevention. In Pakistan, if we talk about awareness of hypertension, it's 50%, treatment is almost 25%, and control goes as low as 12.5% at a national community level. So the question I'm going to leave all of you with is, are we ready for an NCD epidemic? Is it now time to shift from primary prevention and a treatment of CVD from specialists down to primary care? We came up with this project by the name of PREACH, which is looking holistically through a conceptual framework at hypertension from an individual to a community, to a workforce, to a referral pathway, to a national registry and a policy level. So it's all encompassing. And it has 3 different points where we will be working, and we've started working. We're looking into the supply side of things. We're looking into a demand creation, and we're looking into an enabling environment. And I'm just going to unpack it, and this will be my last slide, second last slide, and I'll stop. So on the supply side of things, under Project PREACH, we're looking into development of a standardized curriculum with the Pakistan Hypertension League. This has been done in the last year. And now it has been endorsed by 3 societies, the Pakistan Hypertension League, the Pakistan Cardiac Society, and the International Society of Hypertension, ISH. This is one standardized guideline, out of which we have developed a very simple level, 6 to 7 CME level curriculum. Based on that, we'll be doing a train the trainer approach nationally for capacity building of primary care physicians. So they're all on one page at how to treat, diagnose, and manage hypertension in the community. It will be followed up by impact assessments of the knowledge, attitude, and practice shift of these GPs. So this is on the supply side of things, that we are creating a workforce of individuals, which is primary level care physicians, so that once people who are diagnosed with hypertension land up in these small primary level clinics, these GPs, etc., are ready, and this workforce is ready to treat them on a standardized level and curriculum and practices. On the demand side of things, we felt that it's high time now for a country like Pakistan to shift to home blood pressure measurement. We're doing research studies in which we are comparing standardized random home blood pressure measurement techniques against ambulatory blood pressure. We have done 2 of these, and it will be followed up with a 3rd study now, which we will be publishing very soon. This is a very cost-effective means by which individuals sitting in their houses can measure their own blood pressure randomly across the day. And by this means, we also are focusing on eliminating masked hypertension and white-collar hypertension, which is a major thing, as we all know, for clinic-based hypertension measurement. We are creating a mechanism of self-screening and then referral to these GPs and a mapping of GPs so that individuals themselves know where to go to in the community if they're looking into hypertension. We're again looking into a massive community awareness through print media, through mass media, through DVCs and TVCs and radio shows and digital and offline models for hypertension. And we cannot forget that unless we involve the government and donors and create an enabling environment, we will not be able to look into a shift of hypertension from tertiary down to primary level. So in our model here, we're looking into policy inclusion of hypertension in primary care package. We've already started talking to government counterparts, both provincially as well as federal, to include in the government ADP budget for hypertension. And similarly, we are in talks with multinational and bilateral donors for funding, at least to show a private sector model if we are to make a focus shift from tertiary to primary and from treatment to prevention for CVD, in this case, hypertension. And across all of this, for all the GPs that we have trained, we are creating a national data registry for hypertension so that we have exact numbers of what is happening. So we have an advocacy committee, which is national level from KP Islamabad, from Sindh, Islamabad, and Sindh, Balochistan, etc. And all these people are helping us advocate for this project at government levels, etc. These are our different scopes. The project is all encompassing. We are talking to donors and funding agencies, collaborating partners, academic partners, endorsements and implementation partners, technical partners, and policy advisors. The PREACH curriculum is made. The training impact assessment forms are made. The train the trainer model is as such that we have one principal trainer and we have 15 regional trainers who are all sitting in their regions, trained on one particular, I'm going to show this slide, trained on one particular standardized curriculum. So we've picked 7 or 8 regions nationally. We make these master trainers, and then these master trainers go down and train. So we train lead trainers regionally who go down and train master trainers who are sitting at a district level, who then train GPs who are sitting within a community, so that it's an easier to train model to 3 different tiers of workers. In 2 years' time, if we roll this out, we would have trained 5,000 GPs and a total beneficiary of patients who would be treated, made aware, or preventive would be 1.3 million. So it's a massive impact, as you guys can see. I'm going to skip this. These are various communication, community awareness activities that we will be carrying out. If anybody is interested, they can later reach out to us for partnership, etc. And an enabling environment part, if anybody again is interested, they can come out. And our 4th national guidelines are being published. They have been published, but now they'll be published in a scientific journal, JPMA, for wider level citations. They'll be out on the 11th of August. So if anybody is interested, you can look into this. So thank you so much for your attention. I'm sorry if I went over time. And sorry, Dr. JAHANZEB, if I took your time, I'm going to stop here.
Yeah, WAJIHA, thank you very much. You are right there on the dot. You don't have to apologize. Thank you. So I'm going to share my screen. Just let me know that if it is visible or if it is not.
Yes, it's visible.
Perfect. 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 And I'm audible as well, right? Perfect. So thank you very much, Dr. Sarfaz, and thank you very much, Dr. Uzair. Also, I'm grateful to APPNA and Merit for inviting both me. My name is Dr. JAHANZEB, and I am Director of Medical Affairs, Pharmacovigilance and Clinical Trials at Getz Pharma. Thank you very much, WAJIHA, for sharing your wonderful projects. We are at Getz Pharma are very, very proud of these two great initiatives. My topic of dialogue for next around 15 to 20 minutes would be how Getz Pharma is unlocking the knowledge gap and trying to build up the research ecosystem here in Pakistan. When I was preparing these slides, I looked across and I found a very recent article by Dr. Professor Akhtar. He is the neurologist in KPK province, and only in March of this year, he wrote down this article, and it clearly depicts the areas of improvement that we have, or state of affair of research that we have. So most of the audience has been associated somehow with Pakistan. They must be fully aware of the situations that we all are in right now. So we have inadequate infrastructure, staff, and people are not very well trained, or they are not fully skilled. Also, we lack funding, and obviously there are a lot of regulatory barriers along with the poor quality assurance that we all have to abide by whenever we do the research. So these are the few facts that everybody is actually fully. So knowing these facts, what Getz Pharma is doing and encompassing and removing these barriers and limitations that we all have to face when we start off some projects, mainly in clinical trials back in Pakistan. So to me, research processes or projects need to be done in collaborations. Solitude, the clinical research usually does not pass through very, very quickly. So around 2 years ago, we started this dialogue with Pakistan Neurology Society, and we created research grants. So these research grants were in collaboration with Law University and also Pakistan Society of Neurology in two areas, that is Parkinson's disease and epilepsy. And a very transparent method of approval of various clinical research projects were created. There were 9 different professors of neurology, including Dr. Wase from University, Dr. Mehona, she's a program director for neurology and Shifa, and there were many other important clinicians and researchers there. So far, we have approved 9 projects, and there are 7 projects at various stages of completion, including there are few projects which are. So through research grants, we have tried to improve the overall ecosystem in neurology, specifically in 2 areas, which is Parkinson's disease and epilepsy. Our collaboration also extends. In the world, we see that the collaboration between academia, pharmaceuticals, and also hospitals or institutes happens very, very frequently. And they all collaborate together to point or create something good for the overall public. So Getz Pharma, last year, we had a collaboration model with one of the leading university of Pakistan, which is JAVED, and they train a lot of public health people coming out of the both in bachelor's and also in master's for master's degree. And Bakai Institute of Diabetes is a very renowned institute. So we all sat together and we created out a collaboration model to improve the overall ecosystem in Pakistan. So at Getz Pharma, we are providing the technical expertise. BIDE is providing a lot of data, and the JAVED is utilizing the advocacy because they can easily reach out to the to the government and to the public stakeholders. Another method of collaboration is Getz Pharma. It is in a strategic partnership. It is an unrestricted grant to a body which is known as, very popularly known as Health Research Advisory Board. These are about 20 researchers and clinicians, acclaimed clinicians as well. They meet very frequently, and they also conduct many research and many other projects, including increasing the education level of many stakeholders through trainings and workshops. They also have many projects running, and we are in strategic partnership with them. This picture is coming from last year, where the Minister of Health also participated. One of the board meeting along with the other members here in the. You can see our CEO and other people are also part of this. Now we'll skip that. Now we'll move to what we are doing. Research in medical education. So Getz Pharma, as you are fully aware, that Getz Pharma is operating in more than 40 countries now. And in every year, we have different meetings that we do across various therapy areas. 4 of the important meetings that we do every year is, one of the meeting is in the urology area, and alhamdulillah, for the last 10 years, we have been very successfully doing this meeting despite of COVID. And the other important meeting that we do every year, bringing in delegates from 35 different countries, is International Cardiometabolic Forum. Then we have International Respiratory Forum, and finally, International Gastroenterology Hepatology Forum. Wherever we work, we bring along the delegates from these many different countries to come to a point where we have very serious scientific dialogues happening. This is just a picture of last year International Respiratory Forum that we did in Ho Chi Minh City, Vietnam. And we brought in the healthcare professionals, mainly pulmonologists from about 11 different countries. And we had intense dialogue on asthma, CAP, COPD, and IPF. We created a lot of polls around it. And what we did, we translated all the dialogue that happened in that meeting in the form of the publication, which were mainly commentaries. I'm very happy to share that this is a gallery proof just received a couple of days ago from Pakistan, the Journal of Medical Association. It will be released very, very soon. And we thought that the learning of these programs need to be reached out to many other readers, those who can also benefit. So all these 5 different diseases that we discussed have been now documented, and the challenges and solutions for the low-income middle countries have been presented in the form of 4 different publications in one of the supplement of Pakistan Journal of Medical Association. Now we will look into the few of the clinical research projects that we are moving ahead. These all research projects are only because of one fact, that we need to have our local population is different. We need to have local data. We have local context, so we all need local knowledge to be built up. This is just one slide of one of the projects that we started off back in about 3 years ago, known as SafePark. It was safety and efficacy of empagliflozin, which was a relatively a new product that back then in Pakistan, and we just wanted to see the differences that it might have in our population. The project was completed, and the project was also presented at various conferences, including UK Diabetes, AACE Annual Conference. One of the manuscripts for asymptomatic urinary tract infections for Pakistani population was published in PMC infectious disease, and the main manuscript was finally published in the Biomedical Central PMC end of November in Endocrinology, November 20. There are other studies that we are also doing that involves the secondary care professionals, doctors who are looking at the secondary healthcare. And this is just a top line information of one of the projects that we have actually completed this project as well. I just want to share that multiple projects that we do at the different layers of the doctor to collect the various information. The quality of life for data for Pakistan was missing, and we thought that that would be very valuable to create some sort of information and knowledge for our patients. And I'm very happy to share that only last year it was presented in IDF, and very recently this article has been for the publication, and soon we will be having it online. It will be available with us maybe by the end of next month or so. There are other models that we try to build up the research ecosystem back here in Pakistan. One of the models is collaboration with the universities. This is one of the picture of NASH and NFLD project that we started off with Khan University Hospital. This is also an unrestricted grant where we just simply monitor the overall progress, and we ensure that the projects remains on track and on time, both in time and in budget as well. You must be fully aware of very important doctors and director of the CTU, Saeed Hamid and Muslim Islam, and other people are also part of this clinical trial. Very recently, the communication to the society and the communication to the doctors become very important element, and to entice them to join in to build up the research ecosystem here in Pakistan. This is a picture that is coming from May 2023, only a couple of months back, where we presented the interim analysis and full analysis of the 6 different important projects that we are running across, including Safe Parker that was published, quality of life study, iconic NASH study, is RISE, which is safety efficacy of insulin, and to NASH study that we are doing. And in this picture, you can see that these are all the principal investigators sitting and talking to the audience. Another study that we have been doing here in Pakistan, that is an study. It is the safety and efficacy of empagliflozin with or without metformin type 2 diabetic patients. The important thing of this study is that this study we have scaled it up to a global level, involving many different countries. And we started off from Pakistan, and we have 2 sites approval and data coming in. About 40 patients have been recruited in Sri Lanka. We have a contract agreement already signed off with AQ Kenya, and Uzbekistan, Nigeria, and even Myanmar is also very keen to join. Doctors from these areas are also very keen to join us. And we also have 2 research sites approved back in Afghanistan. This is a picture from my last week visit to Afghanistan, and you can see that we have been training, meeting these investigators at 2 different sites, and this is a picture of the investigators training, staff training that we conducted only last week in Afghanistan, and for 2 different sites. There are multiple other projects. It is sees diabetes, which is ethically approved now, and we are working out right now to start off its recruitment of the patients. Glyphosate study on NASH. The study has been approved from ethical areas, including Shifa International, Northwest Hospital, and Karachi as well. And soon we're going to start off recruiting these patients. We are just not focusing on clinical trials in diabetes area. We are also focusing on other therapy areas. This is a small picture, one of the investigators meeting that we conducted in May. This is a medical stone expulsion study, and those who know people in urology, Dr. Salman Al-Khalis is a PI, and Aziz Abdullah and Dr. Zedi, there are many important clinician and researchers have been part of. And soon it's under ethical approval process, and before the end of this year, we'll start up recruiting these patients. These were just some short-term projects that we are doing, but what research processes that we are doing in the long-term area. So one of the project is heart failure registry of Pakistan. This project started off back in 2019 with one pilot project in Tabahat, and now we have scaled it up. We have 2 additional sites, which is Wazirabad Institute of Cardiology and Peshawar Institute of Cardiology. And so far, we have enrolled around more than 1,000 patients. This is a continuous data, registry data that is being generated, and we have been partnering, supporting both in terms of finance and logistics, also manpower to complete this, to start off and complete this project. Another registry example is interstitial lung disease. We have been doing this registry for last many years now. Now we are scaling it up to the international level, including countries where Getz Pharma is operating, including Nigeria, Sri Lanka, and other important countries. And by the start of next year, we will start enrolling patients of ILD in this registry for many different countries. There is another project which is on registry. There are many other projects, but I'm just showcasing, highlighting a few important ones. This is a hip fracture registry. It just started off only this year, and we are just trying to iron out its creases. Right now, this is a session of onboarding of various institutes that we the ecosystem continues. We like to award people and new researchers. This is a picture from Pakistan Society of Gynae-Ops, where we encourage latest young researchers through poster presentations. A jury was made, and we handed out certificates, cash, and other shields to these young researchers. For gastroenterology, again, this year only, we had this jury, and during this conference, we had a poster research sections the entire day that was spent, and we encouraged new researchers through cash prize and shields and recognition for these young researchers that presented their data. Other researchers, that is, we have been signing MOUs with various other societies to start off these research posters, presentations there in their annual conferences in order to facilitate young researchers and appreciate them. This is again another picture that we just signed off an MOU with Cardiology Society for this year conference as well. We are aiming to start out these research awards in 10 different societies in Pakistan, and so far we have done about 5, and we are aiming another 5 more societies that we will collaborate with this. Research and publication area, how we are trying to build up this ecosystem. I'm very proud to share that by now we have completed about 140 publications, and this also been, we have a small booklet that represents all these publications that we have done. One of the important publications I'm just going to highlight here is meta-obesity guideline. This guideline was made by the 5 different societies across Pakistan, and the letter on the left side of the screen, you can see that it's signed by the presidents of 5 different societies. So this has been published. We also work very closely with other societies, including Microbial Infectious Disease Society, and their guideline for H. pylori in Pakistan has been published. And very, very recently, we've prepared and we supported the publication of a clinical nutrition guideline in health and disease. And the letter on the left side, you can see has been signed by the presidents of 10 different societies. So it took us a while, about 2 years, to complete this project. But we are supporting in research and there are other various guidelines that we are working very closely with these various societies to conclude. To develop the entire ecosystem, we have to also collaborate with various journals as well. If we really want to foster, improve the overall research ecosystem. So me and my team has been meeting various editors and chief editors of various important journals here in Pakistan in order to support the cause and also see their bottlenecks and try to improve how we can also support them. Dissemination is very important. So for improving the research ecosystem in Pakistan, we have a separate a podcast series, which is known as Science Capsule, where we invite important researchers across various countries, geographical area. Sometimes I'm the host and sometimes there are other people. You can go to YouTube and see the Science Capsule, various episodes that we have released now and then. The work is not done alone by me. This is my big team that is helping me out in this entire various projects just that I showed you. There are just few projects that I thought are important enough to be talked about. There is there are about 8 medical doctors. I have biostatisticians with me. I have a PhD doctors. I have people working in different public health areas as well. So it has been a really supportive by my team in order to complete these important projects. That's my last slide. I think knowing is not enough. We must apply. Willing is not enough. We must do. And thank you very much. We will be open for the questions that you.
Perfect. Thank you so much, Dr. JAHANZEB Kamal and Dr. WAJIHA JAVED. We're very short on time. I know that the chat box and both the Q&A is lighting up with a lot of questions. And then I think one thing before I even get to that, the 2 things. One thing that I forgot to mention at the outset is that anybody who is attending these, they will get a certificate of participation after the webinars are finished. So that please look out for that. The second thing is that I think somebody was asking if you can share your PowerPoint presentation with them. So if you don't mind sending the PDF to Waleed, he can certainly put it out. And I know that we have the, we also have the YouTube recording of all these sessions. So usually within like 24 hours, that's up on our YouTube channel. So, and Waleed, somebody saying that they didn't receive the webinar certificate yet. So maybe they can connect with you directly, or if there's an email contact, we can put that in the chat box. So with that, I will hand it over to Dr. Uzair for his comments. And I know there are like a lot of interest with both your presentations. So there are so many questions. I don't know how many we can get to, but we'll try to get at least some of them.
Thank you, Dr. Sarfraz. So Dr. WAJIHA, Dr. JAHANZEB, and particularly I would like to mention Mr. Khalid Mahmood for his kind support and, developing his team. My very, very genuine and real compliment to your team. Amazing work. Trust me, amazing work. Extremely structured. And that's the role that the industry should play. And you have gone all the extra miles to bridge the gap. You are into all the professional societies, journal, poster presentation, whatnot really. If I have not seen it, it would have been very hard to believe all these things. So one quick point before we move on to the question answer, please do share the links to all of the resources like the guideline, like the work, like the capsules. So everything we will be happy to share to all of our participants. So share with Walid all the links and the resources. So in the QA, the first question is also related to that can you tell us some more about the national guideline about on hypertension? So just very briefly, would you like to respond, Vijaya? Thank you.
Okay. So this is available on the PHL website, the Pakistan Hypertension League. And if you can wait till the 11th of August, it will be available on the JPMA website as a supplement on hypertension, as a scientific publication. I would suggest you wait till the 11th of August, and we'll send you the link for that. This is something that has been endorsed both nationally as well as internationally, and is a standardized document with the 4th version coming out. So just wait till the 11th of August. Thank you.
Thank you. So the next question is from Gul Senai Mehman. So it's a general comment. You are doing amazing work. Diabetes and hypertension are tickling bomb. I completely understand working condition. Government ownership is not easy. It would be advisable to increase your reach at large as much as possible. I note in Sindh, it is only, there is center in Taba Hospital. So this is just a comment, but there is so much really to grab. There is so many things. Ideally, I'll request you that share the links. So that is a very convenient way that the people, they can explore to, whenever they are free. So there is so much to assimilate in the shortest possible time. You have shared so much information. And by the way, generally when we receive the copy of the presentation, we create sometime the mail, the blast mail, and we send it to all the members. So those are the key points. So that is a very convenient way really to develop everything. So I think we are still just a minute left on the time. So once again, we are extremely thankful to all the participants for their time, for their involvement and maintaining their interest, and particularly to once again, Dr. WAJIHA, JAHANZEB, and Mr. Khalid Mahmood. Fantastic work and amazing work. And that can be a reference benchmark to all other industry players, because I see a big gap between you and all others. So you maintain your lead, and congratulations to going to 40 countries where you are exporting and, bridging the research to all your, countries like Sri Lanka, Nigeria and whatnot. Amazing work. So that's all from my side. Now it's over to Dr. Sarfraz Hasni for formally closing the session. Thank you.
Thank you so much, Dr. Zair. And again, thanks to the Getz Pharma, especially the representatives here, Dr. WAJIHA, JAVED, and Dr. JAHANZEB KAMAL, for their very informative session. And looks like from the interest and response from the audience that it was very well received. So we look forward to hearing from you. And of course, the whole idea behind these webinars is to have capacity development. So we will try to work on that. And then to all the participants, we will see you in another 2 weeks. So look out for another announcement. And lastly, but not least, a lot of thanks to Walid and the technical team behind these webinars, to managing this behind the scenes. There's a lot of work that goes behind the scenes, but kudos to all of those in the tech who are helping. So again, thank you so much, everyone. And we'll see you in about 2 weeks. So till then, so long. Khuda Hafiz. Inshallah, we'll see you everyone later.
Very much. Thank you. Khuda Hafiz.
Thank you. Allah Hafiz.
Thank you. Thank you.